Good evening, everybody, and welcome to this evening's Initiating End-of-Life Discussions in General Practice webinar. My name is Samantha and I am your host for this evening. Before we kick off, I would just like to make an acknowledgement of country. We recognise the traditional custodians of the land and sea on which we live and work, and we pay our respects to elders past and present. Okay, I'd like to introduce our presenters for this evening. We're joined by Associate Professor Joel Ree and Miss Anne Meller. So Joel is an Associate Professor at the University of Wollongong and is a GP with a special interest in end-of-life care of patients living in the community and advanced care planning. And Anne is a nurse consultant specialising in advanced care planning at the Prince of Wales Hospital. So thank you for joining us this evening, Joel and Anne. And I'll hand over to Joel now to take us through our learning outcomes for this evening.
Thanks, Sammy. And it's really great to be back and being able to facilitate a webinar. I think I was here late last year, and it's great to be with Anne as well. So welcome, Anne.
Thanks, Joel. Hi, everyone.
So just a few learning outcomes this evening. So by the end of this online QI and CPD activity, you should be able to recognize the difference between advanced care planning and advanced care directives. You should also be able to identify patients with whom it would be appropriate to initiate conversations regarding their end-of-life planning and demonstrate a sensitive approach to breaching the topic of end-of-life discussion with patients. So advanced care planning is an important process, allowing patients to plan for future care for a time when they're not able to make their healthcare wishes known. And the process involves a patient thinking about their values, beliefs, and wishes. And it's best if advanced care planning happens earlier in life when a patient is still well. Creating an advanced care directive can be part of advanced care planning. So late last year, we actually spent a little bit of time thinking about advanced care planning, and I understand that the recording from that webinar session is available for interested people to have a look.
It certainly is, and when we send the post-webinar email around before the end of this week, we will include the link to that recording as well, so that anybody that wants a bit more of an in-depth idea about end-of-life planning and the law, which is what the previous webinar was on, you'll be able to watch that recording.
Yeah. There's a useful website, and I think there's a link at the bottom of the slide. You can go to that, and it's got useful information, I think, for health professionals, but also patients as well. So that's something really worthwhile having a look at if you're not aware of that resource. There's also another resource which is available on a slightly different website, and you can once again have a look at the link at the bottom of the slide. But basically, I think initiating end-of-life discussion is, well, we can obviously talk about that today, and sometimes I think it's quite common for health professionals and doctors to get worried about this. And a common question is, well, is it appropriate for me to tell my patient that they may die soon? And people get worried that it might lead to complaint or it might lead to a dispute. And I think that's definitely something that does worry a lot of people. In your experience, Anne, is that a common sort of worry?
No, well, Joel, as you know, we've been working on a project together where we asked patients in outpatients clinics, with the blessing of their specialist, we approached them, having identified them through some of the tools that Joel will go through, and half the people that we approached, or close to half of them, were all very interested to hear more, get more information about planning ahead, advanced care planning, thinking about who they could appoint to make decisions and things. So I think it's something that's out there topically. The Planning Ahead Tools site that you have there is the government portal for wills, power of attorney, and enduring guardianship, and it also has some references to advanced care planning as well. So that's a one-stop shop to go to. But I think people are, once you ask them in a sensitive manner,
Yeah.
you don't say, "Oh, I think you're going to die. Do you want to do this?" I think there's another way to do that. But being cognizant of their problems and raising it just to see what their issues are it's a good opportunity, and people seem happy that it's been raised by health professionals.
Yeah, so it's something that often patients and family are more than happy to talk about, but health professionals sometimes can be a little bit too worried sometimes
A
about
bit
it.
nervous, yeah.
Yeah. So what is an advanced care directive? So an advanced care directive is something that allows a patient to identify what healthcare treatments they would like to have or refuse. It also allows a patient to record their specific wishes regarding future care. It's really important to realize that it can only be made by an adult with decision-making capacity. What about other people, so children or people without decision-making capacity? How does it work there?
Well, for children, they come under the I guess their parents give consent for them until they're 16 or to 18. I think there's a grey area in the 16 to 18-year-olds. So I'd sort of refer to advanced care directives for people 18 years and over. But I think there is a bit of a gap there in the 16 to 18-year-old group. I think the younger, the more mature 14 to 16-year-olds could probably have some conversations, but I'd be wary about doing advanced care directives without a lot of medical and legal input into understanding what their wishes and concerns are. But for a directive to be valid and legally binding, it needs to be done by someone with that decision-making capacity. So the other option is people doing a plan, which might just be them writing a letter about what's important to them and they just want to give some guidance, but it may not be something that might be acted on in, I guess, a legal sense. But to be valid and that legally binding term to be used, it's got to be made voluntarily by a capable adult. It needs to be clear and unambiguous. It needs to extend to the circumstances at hand. So the voluntary is good. The capable, I think, is probably the thorny part that often comes up. We might talk a bit about that later.
Excellent. So a few questions are coming through already, but we'll probably, as we go and through the webinar tonight, we'll try to get to some of those questions and try to answer them. So why is an advanced care directive important? Making an advanced care directive is an important part of advanced care planning, and also because none of us really know what will happen in the future or can predict what might happen with our health. Some patients have firm ideas about how they want to live the rest of their life, including conditions and treatment. And I think in crisis, family may find it difficult to decide what treatment is best for the patient. So, Anne, did you have any thoughts about some of those points?
Well, it seems that it's easy enough to ask people about organ and tissue donation, and this often gets wrapped up together with that, where people think about that as sort of a gift to give to people. But I guess another gift to give them is, family members and friends, is to say, look, I've given this some thought, and so I don't want you to be in a difficult situation or in that stressful time if I can't speak for myself and I'm at an irreversible point in my life. So, we talk about organ and tissue donation. We also talk about younger people, unfortunately, having head-on car accidents and having awful, like this is a kitchen table conversation. My children, they're adults now, but they've been pretty sick of it for a long time. But I think it's something you can just raise as, family lunch or Sunday lunch with the family, to just say this is an important discussion for me to have, and try and just not shut it down when people want to raise it.
Excellent. So GPs or other healthcare professionals can really help patients prepare to make an advanced care directive. So they could provide information to patients regarding patient health and aging, They could encourage patients to think about their values and wishes for treatment, suggest that patients talk to family and friends about this issue and identify their person responsible, and provide websites with further information. So, and who's the person responsible?
I was wondering if you covered that in the last seminar, but so if someone can't provide their own consent to treatment, there's a legislated hierarchy of people that the doctor getting consent or who requires consent for a treatment to go ahead needs to approach. So the first person in that hierarchy is an appointed guardian. And so if you ask a room of people, how many of you got an appointed guardian? Most of them will say no. But enduring guardianship is an option there that people should consider. So if you haven't got an appointed guardian, the next person you should be looking for is a spouse, and that spouse includes same-sex partners and de factos. Okay, so a lot of people don't have a guardian, they don't have a spouse. The next person on the hierarchy is a carer. So a carer is not a paid carer like the nurse in the nursing home or the community nurse or the home care worker. It might be a neighbour. And it could be a family member who provides support on a regular basis, but they're not paid. They can receive a Centrelink allowance, a carer payment or carer allowance from Centrelink, but it's not a paid job for them to do. So if you haven't got a guardian, you haven't got a spouse, you haven't got a carer, the next person in the hierarchy is any other relative or friend with a close and continuing relationship with the person. Now, if you talk to a room full of people, that could be, for many adults, it might be siblings if they're not married or they're not in partnership arrangements and things, or they might have adopted children. So it's very stepchildren. We live in very diverse family arrangements these days. And maybe the person in that hierarchy mightn't be the person they want to actually be having discussions. So for each of your patients that you see in front of you, if you're starting to raise this, just think about that person responsible hierarchy, because knowing who that person would be, say today, and say, the patient in front of you is a lady and she's got a husband at home. Maybe her husband's very impaired or he's got dementia himself, so she's going to need to find somebody else. And often people have got one or more children or close friends, and so it's good to engage them to say who can speak for you on your behalf if you can't do that for yourself. So just knowing about that, and I think that helps you approach it when you're wanting to look at it for all the patients in your practice.
And obviously GPs and other healthcare professionals also have another important role in helping patients, don't they? So they could also provide them with websites with further information. So I think we covered a couple of websites previously. And I think, Anne, you're also going to talk about...
I'll talk about the New South Wales health ones, and I'll probably mention a couple of others. But the Planning Ahead Tools site, you just Google Planning Ahead Tools. That's, as I mentioned before, the information on wills, power of attorney, enduring guardianship, and there's a little bit there on advanced care directives. In that site, there's actually a link, which is legal resources for health professionals. And that's the health law reference that you'd had in a previous slide, Joel.
Sure.
Or we had in a previous slide. Sorry. So in terms of making an advanced care directive, so this is the Ministry of Health's site. It's basically the internet site banner. You can click on public. There's boxes of information about children and family and more generic health information. In the more information area, there's an advanced care planning link. So you can click in there, and that brings you up to 6 pages with lots of sidebars in it that you might have seen in a previous slide also. So as Joel mentioned before, there's a brochure available in about 11 community languages. So that's just advanced care planning, making your wishes known. And this booklet, Making an Advanced Care Directive, is you can just Google Making an Advanced Care Directive if you want to go straight to that. Joel and I have been in an ongoing project looking at reviewing this document that was developed after a lot of review from the Ministry of Health. Lots of groups looked at different documents, and it wasn't to prescribe one particular form that everybody has to use, not at all. People can write whatever they want on whatever format they want. It just needs to meet those validity requirements about competency, capacity, that it's specific and that it needs to be valid. So this is a booklet that just has some information about advanced care planning. It covers sort of broad things. It's in reasonable print font. There's plenty of pictures within it. And then at the back of it is a form that people can complete that just talks about who their person responsible is, have they appointed an enduring guardian, what would be unacceptable for them in terms of an irreversible illness where they're not likely to recover. And then it goes on to ask about resuscitation and treatments and if they were dying where they'd like that to be. Not everybody wants to die at home. Not everybody wants to die in hospital. So we reviewed this with input from our clinicians, the patients and carers that were involved in our study. And so this is the revised document. It was updated in November last year. But if you've utilised it previously, we're more than happy to accept. You don't have to go back and redo it again with patients just because this is the revised version. There's just been some typos corrected and a bit of wording rearranged, but it's been a good resource and it's been well received by patients and families. You can also get hard copies from the Better Health Centre, and I don't know, Sammy might be able to forward that, but you can, the Better Health Centre, we've got an email address, or you can phone them on 9887 5450. That's a Sydney number.
Great.
That helps.
Excellent.
So where's an advanced care directive kept? Well, we'd like it to know that it's not in the top drawer or that it's with their will because, oh, yes, I've done that or I've done enduring guardianship and my solicitor's got it. We need it when the time arises. So where do we keep them? We suggest that people give copies to their directive. You might find that if you don't ask, patients have actually done this before and they thought, oh, I didn't talk to my doctor about it. So you might wonder about what health information they've got or what it's based on, or it might just be on their values in terms of their beliefs and things. So we suggest that patients give their GPs, their person responsible, if they've got a guardian or a family member, a copy. And then if they come to hospital, to bring a copy with them to hospital or to outpatients, those sorts of appointments when they come. In our health district, as part of the project we spoke about, and we became aware of these documents, and if the patient agreed, we've scanned them in and uploaded them into the medical record. And then we create an alert for that, so that continues once they're discharged as well. And this process is being rolled out subject to some policy sign-off that we're doing in our area, which is South East Sydney Local Health District, and we've worked in partnership with Sydney Local Health District and Concord Hospital. It's also an accreditation item asked for the National Standards Safety and Quality of Healthcare. So it's going to be on every hospital's agenda, if it's not already, as looking at asking patients for these, do they want to change them? Do they want to revoke or revise them? Giving them that opportunity and then following that through, hopefully with their discharge summaries, that if there's been discussions around those things that the GPs are aware once they go home. So on a hospital inpatient flowchart, we use PowerChart. There's actually a tab that has advanced care documents there, and so staff can see that advanced care directives and enduring guardianship documents, where we know about them, we upload them and we're then aware. So if we don't know, we don't know, do we? So it helps if we know that they're available. So this is still part of the Ministry of Health site. So this is the health professional information. Dignity, respect and choice, the advanced care planning for end of life for people with mental illness. That's the health professionals guide. There's an introduction for patients themselves. It's not a consumer wellness guide or a mental health plan, but it goes into more detail regarding patients who are under the Mental Health Act or community treatment orders, who are involuntary, just some of that crossover between the Guardianship Act and Mental Health Act. But it doesn't have an actual form or anything on that, but it basically supports all those principles of encouraging people to provide, have a say in their treatment around, and it's probably more geared towards the end of their life, for patients who have mental illness, not to just write them off because they have a mental illness, to try and include them in their support person as where possible. End-of-life decisions, the law and clinical practice. This was developed as part of the Ministry of Health's 5-year action plan, because clinicians worry about the law and the end of life, like can you override a directive, and what if the family's objecting, and what if everyone's fighting? So legal academics from Sydney University and Queensland University of Technology, as well as senior clinicians and myself, were involved. It can be accessed by the Planning Ahead Tools site, and there's a bar at the top, legal, that's information for health professionals. That brings you to the health law Planning Ahead tools. So they're sort of a little bit interchangeable but a bit clunky. But just by Googling health law will just bring you to academic faculties of all the unis, so that won't help. Queensland University of Technology also has a great portal on end-of-life law, and they've got clinician online training and workshops. So anyway, back to New South Wales. The New South Wales Department of Justice and Capacity Toolkit, this is a really good resource, but it was developed about 10 years ago. And since then, we've seen a push, given the United Nations Convention on the Rights of People with Disability. We're talking more about supported decision-making rather than people are competent versus incompetent. It's not black and white. It's more on that spectrum, and doing everything we can to support people with in making their own decisions. And that might just be they're able to say who they want to make decisions for them, or to think about that stuff. So that language is more around supported decision-making. The Guardianship Act will be replaced by 2021, but it's still what we work with currently. And so the Guardianship Tribunal, the Capacity Toolkit, you can order hard copies from the Department of Justice, or you can just download the link and it takes you to that Capacity Toolkit. But it's a very good ready reckoner around all the different types of capacity required around wills, power of attorney, testamentary capacity, and explains all that in sort of fairly easy language. The Guardianship Division of NCAT, who used to be the Guardianship Tribunal, and it's now a much longer name, they've got really good fact sheets on the person responsible, so that just gives you a bit of an outline of the rights and responsibilities of the person responsible, and it also talks about the levels of treatment, like urgent treatment, minor, major, and special treatment. And they've also got good information on substitute consent. So that's just some good other links that are probably worth exploring should you see fit.
Yeah, thanks, Anne. That's really useful, and an excellent overview of the various resources available for GPs and health professionals. So we're going to just move on to identification of patients. So I think a lot of us at this point would probably be convinced that advanced care planning is important. The next question that forms in my mind, at least, is, which patients do we do it on? And in the previous slide, I think we said that advanced care directives can be completed by any adults. But I think sometimes it's worthwhile thinking about resource allocation perspective, that we can see ourselves as precious, valuable resources, and sometimes we want to sort of target patients who would probably, target patients where advanced care planning would be much more relevant and important. And I think there are certain groups of patients where that's the case. So first group of patients are older patients. So for instance, people who are 75 years or older, and people with life-limiting or progressive disease. And the reason for those patients is that they're just much more interested, and end-of-life decision-making is more relevant for them. And also they're more likely to have end-of-life care needs. So that's really important. Second group of patients are people who are suffering from illnesses that are likely to lead to loss of decision-making capacity, so dementia, neurodegenerative conditions, etc. People who have uncommon treatment preferences. So an example we have here are people of certain faiths who are against administration of blood products. So and other people may not have particular religious beliefs, but they might have strong and uncommon treatment preferences. And finally, people without any close relatives or friends who could make decisions for them. And I think Anne sort of mentioned sometimes you do have close relatives or friends, but sometimes you do want a specific person to make decisions for yourself. So I think it's a pretty broad sort of number of groups, but that sort of narrows down the field somewhat. But obviously, any adults who are interested in having a discussion with these issues, it'll be relevant for them. Yeah. So there are several approaches to identifying patients who are more likely to have end-of-life care needs. And first approach really is just using the clinician's intuition, and that's just your gut feeling. And that's when you sort of think about a patient and you just feel, well, I think this patient might benefit from having discussion of end-of-life care needs. But that's often people with more experience, they rely on intuition and it works well for them. But people who are sort of just starting out might need a bit more guidance. And a useful tool that's been developed, and it's sort of become quite commonplace even in Australia, was developed in the UK, is the surprise question. And that surprise question is, would I be surprised if this patient died in the next 6 to 12 months? So you don't have to ask this question to anyone. You don't have to actually physically, literally ask it to your patients. It's something for the clinician to consider. And if the answer to this question is no, I wouldn't be surprised, then that actually means that patient may have end-of-life care needs and might benefit from having these discussions. There are even more structured tools, which goes beyond the surprise question, and we're going to have a look at a few of them. So one tool that's also been developed in the UK and Scotland is Supportive and Palliative Care Indicators tool. It's called SPICT. It doesn't quite I think C and the I switched over, but it makes it's easier to pronounce this way. If you can actually go to SPICT website and you could actually download free copies of it. There are several versions of it, but a commonly used version, I've just put it up on the slide, and it's really useful because it's got it allows the doctor or the health professional to think about general indicators of poor or deteriorating health. So these are things like hospital admissions, unplanned hospital admissions, just unexplained weight loss, etc., etc. And then there are specific clinical indicators as well. So things like metastatic cancer, heart or vascular disease, kidney disease, liver disease, dementia, frailty, etc. So it gets you to think about the disease, but also about the whole person. And that's quite a useful tool to supplement or complement clinicians' intuition or the surprise question in identifying patients. Something else that's been developed this time in Australia is something called Crystal. I think Crystal might actually, it makes it fits in with it makes better sense. But it's criteria for screening and triaging to appropriate alternative care. It's Crystal tool was originally developed for the acute care setting in Australia. It's fairly recent development, so you may not be, the listeners may not be necessarily aware of it, but because it's developed for acute care setting, it looks at things like age, the recent hospital admissions, past medical history, frailty, level of consciousness, vitals, urine analysis and ECG results, etc. So whether you could apply this to a patient right in front of you who walked into the surgery and you're speaking to, there can be challenges to that, but definitely, so for instance, in nursing homes and other places, there may be a role for it. So if you're interested in having a look at this tool, you could go to the link which is provided there, and I think it's open access publication, so you can just have a quick look at that. But it's something that's recent development, Australian, but hasn't yet been widely used in general practice. Something else that's been developed, this one's Canadian, so we're sort of doing a whole tour of all the rest of the world, the globe. This one's called HOMA. So people are coming up with different acronyms, which yep. And this one's Hospital Patient 1-Year Mortality Risk Model. So you could, just from reading the title, it sort of gives you it attempts to predict the mortality risk in 12 months. And it can be calculated using hospital admissions data. So it's quite attractive to hospital-based clinicians in particular, because you don't even have to see the patient. You could basically just look at all the routine data that's collected in a hospital admission, and you could actually work out that person's mortality risk. So, you know, whether you can apply this in your general practice, I think, you know, that's a question. But if you're interested in this, then you could have a look at look at the link, which is on the slide as well. So how to identify patients in a busy clinical practice. So I think we talked a bit about 3 or 4 different approaches to identifying patients. But how do we actually use that in a busy clinical practice where, you know, every 15 minutes you got a new patient? And I think the key message here is there's no right or wrong approach. We're not mandating. I don't think neither Anne or myself would think that you got to use a particular approach. It's what works for that practice and for your patient group. And how I thought about this is really 2 ways. One way is opportunistic. So basically, when a person is in front of you, and often you sort of finish your consultation and you might have a couple of minutes to spare and you're thinking of doing some preventative activities or other activities, then there might be opportunity to quickly screen the patient using the surprise question or using SPICT. And if you feel that they could benefit from having some discussion about end-of-life care needs and advanced care planning, then you could actually provide some information about that and get them to come back. So that's one approach. The second approach is really much more systematic, and that's sort of incorporating into existing systematic approach to assessing patients. And a good example, which you know, a lot of GPs do nowadays, is 75 and over health assessments, or when you're actually reviewing a care plan. And that's a good opportunity once a year to go through with patients, you know, their healthcare needs, and it might be a good time to provide some brief information about advanced care planning. And if they're interested, they can come back for a longer discussion. So, and what do you think about these 2 approaches? And I
think similarly, when I talk with community teams and community service providers, I sort of put it to them similarly, like we're just trying to update our records, or do you do a mail out to everybody? I think we did some work previously with practice nurses, and one nurse said, I'm just going to mail everybody who's 75 and over. And I think she got one grumpy letter back, like, take me off your mailing list. How dare you? So that's sort of just one way. Do you do a blanket mail out, or do you sort of, I don't mean cherry pick, but some people, you know them a lot better than if they're coming to you for the first time. And that was what we found in the clinics as well, as the doctor said, this patient, they might be positive for, say, the SPICT or another tool, that we should have this conversation, but this is the first time they've ever been to see me. I've seen them several times and there's a whole lot of chaos going on in the family at home. Now's not the right time. But when we saw them 6 months later, or they'd come back to clinic, yes, now is the right time. So timing's important, and you can have that opportunity, or, as you say, put it into your existing health assessments. Or if you want to be really lazy or not really too engaged, you could just have brochures in the waiting room like that, making your wishes known. That's pretty passive, but it does indicate that you're happy for them to approach you about that. That's probably another option as well.
Yeah, I mean, and there was a recently published study, wasn't it, in Australia, where they found the prevalence of advanced care directive documents in general practice was 3%, wasn't it?
Yeah,
3%.
yeah.
Very. So I guess the fact of the matter is, not many patients have it. So even if we cherry pick, I mean, no one has it, then just doing it on any patient is it's going to help.
Increase your stats.
Yes.
That's a national prevalence study that hospitals, GPs and nursing homes, a lot have been involved in. Be interesting to get this year's data for that. So, yeah.
And I think we sort of talked a bit about opportunistic and incorporating into existing assessments. And I think Anne sort of mentioned about much more systematic approach where you might want to do a mail out and things like that. You could really get sophisticated. So, I mean, if you're, you could, nowadays it's all the rage, isn't it, where you actually, a lot of primary health networks are doing it, and NPS and a lot of other people are doing it, where they're interrogating the clinical database to identify patients. So you could actually do an interrogation and you can identify a certain group of patients, and then you could basically either do a mail out, or you could even decide to insert a reminder into their medical records to discuss when they might come in next and to discuss advanced care planning. So that's another potential approach. So in terms of, so we talked a little bit about how do we identify patients, but let's say we identified someone, and so in your mind you want to actually have a discussion. So Anne, what do we do?
Yeah. So I think I get asked this question from senior nurses and clinicians who are all like GPs, you really busy practice and clinics, going, I haven't got time to go into this in a big detail. But I think the trigger question I would ask would be, who would you want to make decisions for you if you couldn't do that for yourself? And if you've got in the back of your head that person responsible hierarchy and you know that patient, you're going to say, well, who you want isn't going to be who you might get. Or if you want someone in particular, you might want to think about enduring guardianship. And we will send you the links for the enduring guardianship. And then or you might just want to say, look, I'm just wanting to get my records straight here. Have I got the right person about who I should be contacting if something happened to you? We find in hospitals the person that comes in as the person with the mobile phone in the car, they mightn't be the person you want making consent decisions for you if you can't speak. To even just asking, have you appointed an enduring guardian, that leads into that. Have you done an advanced care directive? You usually get, no, what's that? And that leads you to say, well, this is just some information. I raise this with all my patients. You might also get that cue from the patient saying, oh, my sister's in a terrible situation. She can't speak. I'd hate that. And it just gives you that opportunity to drill down a little bit more as to what is it about having a stroke that's so bad. Because, I mean, you could have a little stroke or a big Bertha stroke and 500 shades of grey in between.
Yep.
So it's are they fearful about mobility or swallowing or recognising their family or their speech? So while not being nihilistic about it, to try and talk them through what those things are. So in identifying about who will speak for them, who that will be, you're trying to understand who that person responsible is. It's maybe it's going to be your wife. Is that okay? And they might go, no, we lock horns on this issue all the time, and we've got very different ideas. Or they might be quite happy that their spouse or their adult child. We've got a question there about, we've got a couple who are same-sex partners who've been together for 20 years and the hospital disregarded that. Well, that's actually the person responsible for that, for those same-sex partners. From one of the GPs, I have a same-sex partners who were not married but together 20 years. When one had breast cancer, the hospital excluded the partner and later they got married so they can be next of kin for each other. Well, yeah, they were actually next of kin. They didn't have to marry just for the purpose for the hospital.
Yes.
I hope that the marriage was a happy one and a good one. But, the hospital did the wrong thing in that regard. But, this is something that hospitals, the Guardianship Act's been out since 1987 and health professionals still try and get their head around it.
Yeah.
So just in terms, I don't want to run out of time or talk for too long, but just talking about who that substitute decision maker might be, and then just reflecting on recent health issues after they've been in hospital lately or had an admission, how did that go? sometimes it's awful, but other times they go, no, that was all good. And yes, I do all that again. It was worth the difficulties that I went through. I think just phrasing these things around, look, we're all living longer, so we need to know a little bit more about this. So, yeah, brochures and booklets on pamphlets are available. So there's a lot of resources out there. Patients probably want your advice about their medical condition, and possibly they need referral on for specialists for other opinions as required. And they don't have to do an advanced care directive. But it helps to know in the suite of things like to ACAT and services that an advanced care directive might assist them or might meet their needs. I'll just go on now to talking about capacity assessment. I try and avoid doing a capacity assessment.
Yeah.
It's not really within, as a nurse, I'm a senior nurse, but it's not really within my scope of practice. But at any time I'm looking in any conversation, like I'm having quite a nice conversation here with Joel and Sammy, but if Joel or Sammy started saying some unusual things, I would have a bit of a trigger to go, hang on, something's not quite right here. So while we're having a conversation and we know this person, they can understand the facts and the choices involved, they can weigh up the consequences, they can communicate that decision, then they pretty much have capacity. The Ministry of Health document, for nurses, that was an issue. They didn't want to sign off capacity assessment. We left that for neurologists and geriatricians and GPs and people who know the patient. But if we're assisting a patient, we might think they've got capacity. The signatures on the back of that document, if we're witnessing it, we're saying, I've got no reason to doubt the person lacked capacity at the time it was signed. So you need to have a fairly radical capacity assessment's probably an hour, webinar in itself.
Yeah.
You need to have a very valid trigger to go off and assess someone about their mental capacity. But education, looking at their environment, reversible effects of medications, delirium, depression, putting them in a good space and giving them the opportunity to have a say in their own welfare, that's the aim of sort of enhancing that. I've had patients say to me, well, what would you do? And I think, okay, we're not doing any more advanced care directive here. Because so these patients are often quite motivated and they want to fill things in and they want to write notes and they want to tell us what they think. That probably provides a nice segue. Some people don't want to do a directive. They just want to write a plan that's more about their values and what's important to them, to give a bit of guidance.
Yeah, and I think obviously, I think most GPs, including myself, we'd probably feel a bit uncomfortable about doing a formal assessment of capacity either. So I think once again, as what you said, Anne, if we have reason to doubt someone's capacity, in that case we'll raise a flag and probably refer at that stage. Yeah, I think that's a sensible way to do things.
I mean, there's tools to screen mental capacity, but that doesn't mean that they can't. Often people, their mini mental score mightn't be very high, but they still know their values and their beliefs and their wishes and what's important to them in their life. So those sorts of scores, we don't go there. They give you an indication and a screen, but it's not preferable.
Sure. So we've got a case study.
Yeah. So Barry's been known to me since about March 2016. He was referred by his community nurse who attended his wound care. His mother had died about 6 years. She died about 6 years ago. And so he clearly sort of outstayed his welcome in the family home. So part of the agreement in the mother's will, the father had previously died, was that he could stay in the house for a year after she died, providing he was independent. That was the condition. So this is the parents' home. He was the carer for the mother until she died, and he's got 6 siblings, and he's close. He's got a lot wrong with him. So, yes, he's got vascular problems. He's had bypass surgery to his legs. He has persistent leg ulcers with multi-resistant infections. He's had osteomyelitis, osteoarthritis, hypogonadism, hydrocephalus as an infant. diabetes, peripheral neuropathy, and morbid obesity. So, yeah, there's a lot wrong with him. But he also had a lot right. You know, when I got this referral, I'm like, oh, gosh, where do we go here? When I visited him at home, he was 120 kilos, but he was 180 kilos a couple of years prior. So when I first saw him in March 2016, he was 120. He'd stopped drinking 11 years previously and stopped smoking 2 years prior to that. But he really missed that social contact with the club. He thought his community nurse that did his wound dressings 3 times a week was the best thing since sliced bread, and they compared notes on travel. His recurrent infections have left him with the MRSA. In October 2015, he was admitted with hypothermia. He's got supports at home. But he recognises the limitations of all his multiple diagnoses and that they might have a domino effect at some point. So his supports at home are the community nurses. He has a suprapubic catheter and the spinal nurses come and change that, or he gets the ambulance to come. He has personal care, Meals on Wheels, housework for assistance, and he mobilises with the rollator frame indoors. So I got the referral from the nurse, and when I rang him, he said, I want to do an advanced care directive. He was a bit anxious at first because I think my first reaction was, you're pretty young. He was only 62.
Yeah.
I think he thought I was going to talk him out of it, so he was ready to put up a fight because he was pretty determined to do it. He was convinced that he wasn't going to see another winter. His fibro house was pretty cold, and when he was hospitalised, there was a lot of talk of nursing home and amputation, which he refused categorically. He wanted an advanced care directive because he just didn't want that leg amputated. He'd had a few stints in rehab. He didn't like most of the doctors. They tended to be a bit obsessed with his gonads and his genitals. So instead of talking to his face, unfortunately, on ward rounds, they'd go and pull the sheets back. And he just found that quite demoralising and dehumanising. And he wasn't a textbook case, but he was pretty sick of hospitals. The tasks from my perspective, process-wise, I tend to call it Advanced Care Planning 101, person responsible, will, power of attorney. Let's just clunk through all those things. Have you got it? Do you want to do it? Let's get some help in that. But he wanted to stay in that house. So we worked through those things and he could do a plan or a directive eventually. And he seemed certainly capable and competent and very engaged. He was very clear. He was a good storyteller. He narrated his own life. He wasn't expected to live past the age of 6. He'd had a shunt for hydrocephalus removed in his teens. He worked full-time in the town hall until his 50s, and he'd travelled but never married. So what are the risks here? Any day he could get sick and die. Am I implicit in this process of letting a vulnerable human being die? It's his right. He can refuse treatment, sure, but what if he's depressed?
So we've got just a polling question. We're not going to do a formal poll here, but these are the options. So listeners you could actually have a think about these options. So the first option is advising the patient that he's not palliative and therefore advanced care directives doesn't apply. Second one's referring the patient to hospital to discuss advanced care planning. Third one's providing a copy of the advanced care directive form for him to complete and sign. And finally, find out more about what he knows about advanced care planning, why he wants to do it, and his understanding of his condition. So these are the different options. So Anne's going to continue telling us what happened.
So I guess I was a bit worried that this man might have been a bit depressed. So we've got a few rules that we developed with Carmel Pisa some years back in flowcharts, sort of stemming from an overview. So depression along with infections and delirium is often reversible. So we want people to have the best say in their life. So mood-wise, he seemed okay. He slept well. He didn't have any suicidal ideation, no intention from what I could see. Or no. I spoke with his GP and his mood was generally okay. He'd been on an antidepressant longer term, but his GP felt there wasn't any need for any psych referral or medication. He was just being sensible, planning ahead. So my role was to just check what was reversible for him. And we look at sort of pain and delirium, depression, what sorts of things are impacting on this person that are potentially reversible or relevant irreversible conditions so that we want to put them in the best position so they can have a say. So, process-wise, you might be doing a few things at the time, but I had no reason to doubt his capacity, so I didn't formally screen it. There was a bit of light and noise impairments. Those things happen, but I wondered about undue influence as well, and maybe it was at the hospital treating him that he felt sort of forced, that no one wanted, people only interested in, his genitals rather than him as a person. Did he feel so disempowered? And maybe all he needed was a heater and some extra blankets for winter, and along with his community nurse, we got that organised. So does he know the risks and benefits for the treatment? Can he weigh them up? Can he make a choice? At this point, I didn't know if he had thought much about the alternatives, as in a prosthesis, and what it would mean. If he was adamant he didn't want to think about it, then I couldn't force him. But just because someone decides to do something that I think's a bit unwise or impulsive or irrational doesn't mean it's wrong or he's impaired or incapable. So I bit the bullet and asked, what about a prosthesis? What would that mean for you, Barry? And I was a little bit taken aback by his reply. Well, no one's ever spoken to me about a prosthesis, he said, what it involves or what it would mean. I was just gobsmacked that he'd never sort of gone, maybe he'd been so adamant that he didn't want to do that he hadn't got to talk it through. So I just said, look, would you like some information on that, so he could make an informed decision and get the facts involved. As I said, he didn't like doctors very much, but he did like one of the rehab specialists, so we went to outpatients and I met him at reception. He said I could come in too, and apparently the appointment was all my idea and he was going in for my benefit. So he certainly has a sense of humour. And we explained to the specialist the background, and he agreed it was a complex situation. The amputation would need to be higher, not below knee, meaning he wouldn't be able to transfer without assistance. And, was this assistance such a big deal? He already had help at home. No, but his siblings would be pressuring him to move, and that would be the final straw. So I'll just go on. He started writing down his thoughts. And so on the back of an envelope, they say that you can write an advance care directive on the back of an envelope. So this was his attempt. He had a couple of envelopes. Sometimes he's writing. It's hard to see there, but it's easier to read if you had the actual bit of paper in front of you. So he'd gone through the Enduring Guardianship booklet and written questions. He had notes. He was very motivated. So Barry wrote on the front and back, but he let me clarify and rewrite his thoughts in a Word document, and we went along. We started writing a plan. It was more a narrative. We went back and forth. The solicitor read it. The solicitor had visited him at home, done an Enduring Guardianship appointment to appoint his sister, and he put those thoughts and wishes into directions within the Enduring Guardianship appointment, which means the guardian is bound by them. So these are some of the... do we have a polling question now?
We might skip the polling.
Skip the polling. We're probably running out of time. I've been talking too much.
Oh, no, it's good, yeah. But,
so these are sort of ideas. This wasn't Barry's, but you get the idea. We all see these types of... the one on the left was attached to a walking frame. Death is quite okay. No CPR, PTO. And people often mention the retired nurse who had her chest tattooed. Anyway, I digress. After all that, he did an advance care directive. He didn't want to just do the Enduring Guardianship appointment. We emailed several versions to the specialist and GP so that wording was really clear. An OT saw him at home. He's got an electric wheelchair, which he now has, and he goes out. He goes to the club and doesn't drink or smoke there. He's had a social worker discuss final housing options with him. He's a bit resigned to moving, but he's making his siblings squirm and making them do a bit more work around it as well. He rings me every few months to see how I'm going, because I think he tends to befriend healthcare staff. I think things are looking a lot better for him than back when they did in 2016. He just wants to live on his own terms. And I feel like advanced care planning is actually a health promotion or insurance exercise. While you plan for the worst, you hope for the best. And once it's done, you get on to refocus on the good things in life. So that's Barry.
Yeah, no, thanks. Thank you, Anne. No, it sounds like it's something that sort of, it's a real process, isn't it? So it's not just about, someone just filling out advanced care directive form, but it sort of ended up involving so much giving information to Barry and getting new perspectives and new opinions, getting Barry to think about his health and what he wants to do. And he's still obviously,
chugging along.
Chugging along, yeah. So that's I think a really good example of advanced care planning, and just because we're a little bit short on time, we'll just move to a certain slide, 45. So we talked a bit about some tools you could actually use to help your end-of-life discussion, and you could use the link on the slide to download the brochures and template. There's a conversation guide as well. So this one by Dying to Talk is actually geared towards families and patients to have a bit of a discussion. But just something that would be worthwhile noting is that particular one is heavily focused on death. So it's not, I don't know whether that may be something that some of your patients might want to talk about, or, but there is another package which has been developed by the advanceproject.com.au. So that's something that I've been involved in. It actually is a really nice project that's funded by Australian government. It provides online training for nurses, GPs and practice manager. It's designed to be applied to the whole practice, and it actually includes a lot of tools and resources, including a discussion starter, which doesn't actually mention death and things like that. It's still very relevant for end-of-life care, and it doesn't shy away from that, but it doesn't start off by talking about death right from the beginning. So that's something else which might be useful. So in conclusion, Advanced Care Directive is a key part of the advanced care planning process, but it's not the same thing, isn't it? So what's the difference between Advanced Care Directive and Advanced Care Planning?
Well, the planning, as you say, the process. Not everyone's going to do a directive. Some will just say, have a conversation with those close to them. Some will appoint someone to be their decision maker, their enduring guardian in New South Wales. Power of attorney is finances only, so don't get me started on that. It's too late. But a directive and a plan. A plan will give guidance, but the directive has to meet those validity requirements before it can be acted upon. And we'd assess how applicable it is when people are in hospital or at the time.
Excellent.
Decisions need to be made.
Sure. And we've also talked a bit about various tools and resources available to assist patients and health practitioners. And also we've talked about how it's important for GPs to be involved in providing timely support and awareness to patients and their family. So learning outcomes, I think we just to revisit. So by end of this online activity, you should be able to, one, recognize the difference between advanced care planning and advanced care directives. Secondly, identify patients with whom it would be appropriate to initiate conversations regarding the end-of-life planning. And finally, demonstrate a sensitive approach to breaching the topic of end-of-life discussion with patients. So hopefully we've covered all those three areas.
So that does bring us to the end of our webinar this evening. I would just like to say a big thank you to Joel and Anne for joining us here, and also to everyone online who's taken time out of their evening to come and listen in tonight. We do hope you've enjoyed the session.